Welcome everybody who's taken the time to join us today for this special session hosted by Contact and the National Network of Parent Care Forums on the newly updated policy on care, education and treatment reviews and dynamic support registers. Briefly, my name is Amanda Elliott. I'm the Strategic Health Lead at Contact. I'm also here with Jackie Watt. You might want to say hello.
Hi everyone, I'm Jackie Watt. I'm the participation lead at the NNPCF and I'll be monitoring the chat today.
This session, it will be largely our esteemed NHS England colleagues who've helped to create this, this newly updated policy, and it will come in two halves and there'll be an opportunity for questions at the end of each half. Also, Jackie will be monitoring the chat for questions that come up, and hopefully if we've got time at the end there'll be a chance to take some of those questions. So first of all, I'm delighted to introduce Scarlett Millward, who's the Programme Director for the National Children and Young People's Team for the Learning Disabilities and Autism part of NHS England, and she'll be talking to us about the dynamic support registers. We also have with us Chloe Haig, who is the Improving Quality Lead for the Improving Quality team for the National Learning Disability and Autism Programme, and of course someone very familiar to most of us, Mary Busk, who's the Family Care Advisor, the Senior Family Care Advisor for the National Children and Young People's Team for Learning Disability and Autism, and my mouth is now very dry with this title. So to start with no more hesitation, I'd like to hand over to Scarlett. I'll be on mute doing the slides, so welcome.
Thank you, Amanda. And for clarity, I'm not programme director, thank God. I'm a programme lead in the Children and Young People's Learning Disability and Autism team. I'm definitely not Tom Cahill. Thank you very much. So I'm going to talk to you, like Amanda said, about dynamic support registers and the care, education and treatment newly published policy. So if I could have the first slide, please. Thank you. So for those unaware, this policy has been several years in the refresh and in the making. So the CETR policy has been around for some time, and it did include reflections on dynamic support registers. But what we recognised is that we needed greater policy around the DSR, which is why we've combined the two into a very long 100-page policy, which you may not have seen yet. So just to talk to you about some of the development that we've undertaken over the last 2 years is that we've worked in co-production with stakeholders across the system. That includes the National Network of Parent Carer Forum and Contact. It includes the Council for Disabled Children and NDTI as well. And lots of people with lived experience and professional experience. And we received over 300 responses from people for things to include. And we'll talk a little bit about some of the things that we were asked to include and what we've included. It also factored in wider system changes, which includes the new NHS operating framework and the changes that sit around that. So you may be aware that in your local area, your CCG no longer exists, and that your clinical commissioning group, they're now known as integrated care boards. And that impacts on the way that the NHS now operates on a larger footprint. We've also taken into account different changes to legislation and wider policies, such as the draft mental health bill that's currently being considered for changes around people with autism. The Building the Right Support Action Plan, that's been updated, and the SEND inspection framework, which now includes dynamic support registers, CTRs, and in some areas, key working. We've also taken learning from system reviews such as LEADER, the Safe and Wellbeing Reviews, and the National Safeguarding Review. If I could have the next slide, please, Amanda. So, update on the publication of the policy. So the new refreshed combined DSR and CETR policy has been published, and it was published on the 25th of January this year. Both CETR guidance and DSR guidance are included, and there's a 3-month implementation period from the point of the 25th of January to implementation, which will be on the 1st of May. If I could have the next slide, please. So for those of you not aware, dynamic support registers are a tool used in local areas to identify children, young people and adults with either a learning disability or have autism or both who may become at risk of admission into mental health hospitals without timely access to dynamic support. In some areas, they are known as at risk of admission registers or dynamic support databases, but they are intended to do the same thing, to identify those people at risk or who might become at risk of admission to mental health hospital without access to the right support. They are also for commissioners to really understand their population needs so that they can commission services that are appropriate to prevent those admissions to hospital. Next slide, please, Amanda. What we recognise, though, is that while policy is great, and this policy is all about developing minimum requirements and minimum standards, it cannot be implemented without local co-production and working with your system partners, which is why the role of NNPC, local parent carer forums and contact forums is so important to develop a dynamic support register that best meets the needs of children, young people and adults in your local area. Next slide, please. So as I said at the beginning, we co-produced this policy, and some of the themes that we received for inclusion were about having a consistent approach to understanding people's needs and the support that they require, that there should be no wrong door when you ask for help, and that it's not always clear how to find your local dynamic support register or who is responsible for it. Next slide, please. Thank you. So, following that, what we recognised and what we need to include is that we have an increased focus on identifying people at risk of admission to hospital, that we have increased focus, what does it say behind that one? Yeah. An increased focus on identifying autistic people, and that we have increased local visibility and understanding of the dynamic support register, as well as increased accountability for integrated care boards. So what that means is that there is a requirement now of local systems to publish how people access their dynamic support register and who is accountable and responsible for their dynamic support register in their local area. Next slide, please. So additionally, what else we included was that there's a greater focus on shared ownership across the system to improve joint working, that our dynamic support registers are responsive to changing needs and presenting risks, absolutely dependent on co-produced local implementation, and that we include a greater focus of children and young people placed in 52-week residential schools and colleges. Next slide, please. So other key changes to the existing processes are that we include a clear way to stratify the needs and risks of people. And in the policy, we've endorsed the Cheshire and Wirral model as an approach to do this, that people have an absolute right to self-refer onto their dynamic support register when they think they need help, as well as the circle of support will also be able to refer onto the local dynamic support register. We also have put a requirement in that the dynamic support register includes people who are already an inpatient in mental health hospitals, and that there are clearer links to commissioner oversight visits. And we've also included a direct link from the RAG rating approach into key workers having a CETR and asking for support for unpaid carers. Next slide, please. So I can now take some questions, if there are any, in relation to dynamic support registers before I hand over to Chloe. I don't know.
Nothing's come up in the chat just yet.
Okay, over to Chloe to talk through the care, education and treatment reviews.
Thanks, Scarlett, and it's really nice to virtually meet you all, and thanks for coming along today and for the invite. So my name's Chloe Haig. I'm an Improving Quality Lead, currently working with the National Learning Disability and Autism Quality Improvement Team. I do come with a bit of a caveat. I'm on secondment. I joined the team in October. My substantive post is I'm part of the senior nursing team for North East and Yorkshire. So I've been learning everything at 100 miles an hour. The information that I'm going to present to you today is something that I've really enjoyed learning about, being part of and being part of the launch, and care education and treatment reviews are absolutely a fantastic piece of work to be involved in. And I've been incredibly lucky to get to meet so many passionate people who are really focused on making positive changes. So thanks, Scarlett. And I'm going to talk to you about the care education and treatment review aspect of the new policy. So a care education and treatment review is a meeting which brings together people responsible for commissioning and providing services. So we are looking at people from multiple different backgrounds, including nurses, social workers, local authority representatives. And this is about people with an independent opinion, also someone with lived experience, or a person with learning disability and or autism, and talking to people, their families and carers. And the main aim of the CETR is to check that the person who is either at risk, so on red on the dynamic support register, so they're either at risk of being admitted, or a person who has already been admitted to a hospital setting, is receiving high quality, appropriate care. And the independent panel have a focus on looking that where possible, we can bring this person back into the community if they're in an inpatient care. Do you want to move on? So like Scarlett said, this policy has been co-produced. So lots of different groups of people and individuals have been brought in to look at positive changes that needed to be made within the policy. So what people told us is that following a care education and treatment review, what happens is actions are made around how to improve this person's care, how to move them into the community. And what we were finding is that people were telling us that actions are often not followed up, and there were difficulties with finding the person who was held accountable for the actions that were made. Physical health checks often not happening, and for those of you who've read the recent publication of the Safe and Wellbeing Review, that absolutely is something that needs a real fundamental change. Advocates do not always attend. I think we could probably change this now from what we know. Advocates do not always attend and are sometimes not asked to attend and know about the care education and treatment reviews. So therefore their knowledge and relationship with the person is limited, and their information that they hold is not brought to the reviews. And people also told us that agendas could be too rigid and are not person-centered and based on that individual's person and their circumstances. So what we've included in the policy is we've included an increased focus on advocacy, an increased focus on physical health, an increased focus on quality of life, and an increased focus on accountability and quality assurance. And what we'll do is, after we've presented these slides, we'll give you a little bit more depth around what we've done to make sure we include those areas and how we've involved the right people. Okay, next slide. So again, things that we've changed within the process of the policy is we have a greater focus on all panel members having equal voices. We've improved the clarity on the escalation process. We've got a greater focus on matching of panel to the person who is on the receiving end of the review. And we've also ensured, as Scarlett said, we're in a real time of change at the moment where we're moving to integrated care systems having delegated responsibility for CETR. So we've made sure that we link into other processes, and that's such as the care programme approach, commissioner oversights and key workers, and looking at senior interveners. Move on. So the key changes to the existing process. So we've absolutely made it clear within the policy of how people can request a CETR sooner than minimum timescales. We have put in steps to ensure that if somebody is having a review, it needs to happen if someone has had a diagnosis removed of learning disability and or autism. So we're making all people aware of that. CETRs are to be undertaken within 6 weeks of admission, even if a community CETR has taken place, to really ensure that we have a focus on making sure that that individual is getting the correct therapeutic interventions to move towards discharge. And also we have introduced that a care education and treatment review should be undertaken for any person moving from one hospital to another. We have given the option for people to have the same person to undertake follow-up review. So if a person wants that consistency, if the family and the person on the receiving end of the review have built up a relationship with a panel and actually they find that helpful, we were asked to build that into the new policy. Payment structures, so for experts by experience and clinical experts, and mandatory training. We're really working together with the children and young people's team to look at how we can quality assure CETRs. So it's not just about ticking boxes to say that that person has had one done in the right timescales. It's about making sure that they are person-centered, that the outcomes are person-centered, and that person receiving the review is really getting something of high quality. And also that the actions are being carried out, because what we were hearing back from people is that the lack of accountability meant that actions were being made and people were really encouraging these actions. However, it would be 12 months down the line and the person would be receiving a further review when these actions were still outstanding. We've also recommended that people receive a community follow-up CTR post-discharge to ensure that there's that robust support within the community. And also a big piece of work that we've done is we are currently supporting integrated care systems and integrated care boards to develop oversight panels. This came out of the Safe and Wellbeing Review, where it was found that that senior oversight really helped to progress things like recommendations or concerns around people's care, and also to keep that oversight of providers and the quality across their system footprints. So I guess this is the important one, and Scarlett, feel free to chip in. This is what's keeping us very busy at the moment. So the DSR and CETR policy next steps. Some of you might have been invited to join me. I think it's either next week or the week after. What we're doing at the moment is we're building some key lines of inquiry. So key lines of inquiry is the document that is used within the care education and treatment review. So it's a template basically. And the Chloe's, there will be 4 moving forward, because what we heard from people is that they didn't meet the needs of the person being reviewed. And we've worked really closely with Mary on this as well to really understand what we need to put into the key lines of inquiry to make sure that the person receives a high standard review. So there'll be children and young people community, children and young people inpatient, and then adult the same again, inpatient and community. So there's 4 key lines of inquiry there. And what this does is it helps people ask the right questions. And I think a real key part of that again fits in with the policy is what parent carers and people with lived experience fed back to us was their concerns around people receiving reviews from panel members who hadn't actually met the person or hadn't reached out to contact family members, advocates, people involved in this person's care. So within the key lines of inquiry, that's how we've managed to really strengthen elements of physical health. So ensuring that when the panel go in and review this person, they're getting that really holistic view. Quality of life, so talking to the person and their family members to make sure that they're getting access to do things that they enjoy and to see the people who they want to see. And there's 2 parts of that. Is there's a sit and see element, which means that the panel absolutely go to where that person lives and has a look around where that person lives and sees what that person can access. And then the other element that we've asked for some help from you guys is around what we're currently calling the face-to-face element. So making sure that they sit with the person and have a conversation around how they feel their care is going, if that person wants to, or they might want a family member with them, or they might point us in the direction of an advocate. So the Chloe's is a really big part of what we're doing at the moment and keeping us busy. Shall I hand over to you, Scarlett, to talk about the code and toolkit?
Yes, you can do. So there's a big piece of work going on to kind of bring this 100-page policy into something that's a bit more operational, and it's aimed at supporting local systems think broadly in terms of how does a dynamic support register, a care education and treatment review fit together? How does that sit alongside the oversight visits? How does that sit alongside oversight across the system? How does that link to your integrated care board? And how does that bring people together to make it a truly person-centered approach? We're hoping to have a draft of that done relatively soon, ready to start circulating it across a lot of groups and a lot of people to make sure that it's hitting the mark that it needs to really support systems to implement this policy really effectively. So I'll hand over to Mary, and then I can see that there's been a lot of questions that we can run through as well. We've been scribbling those down. So should we take the slides down?
Yeah. I just wanted to make a few reflections as I'm here today as well, joining you. So I was part of writing the original care education and treatment review policy and getting education into that for children and young people when I was a member of the National Network of Parent Carer Forums myself. I've also been an expert by experience. I've seen and been part of many community care education and treatment reviews, as well as inpatient reviews, and I've seen and know the importance and value of those to families, children and young people and adults. I've also had a reason to ask for care education and treatment reviews myself for my own son, and it's very important to me that residential schools and colleges have been included in this new policy, because that is where my son now is. You have also got really important roles as strategic partners in thinking about the policy and how you could work with your integrated care boards and integrated care systems to make sure that these are co-produced and they're visible and understood by yourselves and by families and children and young people who need that essential help. We've also not talked much about it today, but there is a very important link between the dynamic support register as well and carers contingency planning. And our colleague Verity Comley, who works in NHS Carers, I'm sure will be very happy to come and perhaps give you a whole session about understanding carers issues and the rights of carers and what carer contingency planning means. I think that it's also really important for us to think together about what families will need by way of information when they need a care education and treatment review, and similarly for children and young people. And I think while this is obviously, we're talking about a policy, we're talking really about something practical and things that are practical, that are really essential and necessary to help children and young people and families get the right help at the right time when they're in points of need, where other systems within SEND are not perhaps, bringing the help and support that they need. Okay, so I think we'll pass on to the questions that you've now kindly posed.
Okay.
Yep. Do you want me to read them out, Scarlett?
Yeah, is that okay?
Yeah.
I did try and scribble them down, but yeah, if you can read them out, we'll do our best to answer.
No problem. So Sarah's asking, first of all, how will you define at risk? What is the threshold for DSR entry?
Yeah, so in the policy, we've included the Cheshire and Wirral model for stratifying a person's level of risk. And it's done on a RAG rating system of red, amber and green. But what we're saying, to implement an effective dynamic support register in your system, you need to work with your partners to define what that means in your area. So we've given an example that has been co-produced up in the Cheshire and Wirral. Local systems may choose to adopt that, but what we're saying is absolutely work together to define what constitutes a person being at red, amber or green on your local RAG rating system, and be really transparent about that. Work with people to define it so that we're all on board.
Okay, thank you. Carolyn is asking, how do they link with EHCPs? Would you think that someone, particularly 18s on the register, should almost certainly have an EHCP?
I think it's needs led, and I think that would need to be factored in whether a person needs an education, health and care plan. It's not an absolute given if they're on the dynamic support register that they'll have one. I think it depends on what their level of education need is. So again, it comes down to that local development.
Yes, and I think also just to add to that, from practical experience, even if you have one, the system in the SEND system and annual reviews won't necessarily address what you need to address through care education and treatment reviews relating to risk of admission. So I think it's looking at all of the SEND and these systems together and seeing how best needs can be identified and met.
100%, 100%. And I think the emphasis on having care education and treatment reviews is that we bring in education and it's absolutely factored in, and that could be an outcome of a CTR.
Okay, Jane is asking, will the DSR register be the responsibility of the new SEND app board coming through the improvement plan? So the SEND and alternative provision.
Yeah, I'm not clear what the question is there, or who we think it, which is that a local board, or are you talking the national board? Where this sits from a national perspective, if we're talking about kind of overall accountability and responsibility, is that the policy is clear that local system responsibility sits with the ICB. The dynamic support register itself may not be administered through the ICB. Quite often, dynamic support registers are very interlinked with key working services, as that's the kind of the route into key working services. So where that sits locally in terms of oversight will need to be determined locally, and I would recommend that you contact your integrated care board to do so.
But I think additionally, you have been able to get into the Ofsted CQC inspection framework for SEND.
Oh, absolutely. So from a national perspective, we are working with our CQC and Ofsted partners to increase awareness of dynamic support registers and CTRs, as well as key working, anything that can make a positive impact on the lives of children and people they want to be aware of. And we also recognise that the 52-week education placements need to increase their awareness of this new policy and what their responsibilities are. So we're going to do some work in that space as well to try and support that too. But in terms of national oversight, that will sit with the Building the Right Support Board, and where local accountability will sit and escalation will sit, that is still to be defined. As we mentioned before, this policy is taking into consideration the new NHS operating model, which does mean that there are changes and we're still working that through.
So I just want to check with Jane, did that answer your question? Is that the question that you taken as you intended?
It did, thank you. Yeah, we're about
Brilliant.
Accountability. Thank you, Jackie.
Thank you, Jane. Right, next question, to do with the DSR. Again, how do we know if a young person is still on it? Will we be informed if they're removed, and if so, by who?
Absolutely. So the to be on a dynamic support register or to have a CTR, you have to give informed consent, or somebody does that on your behalf if you're not able to do that yourself. And there's a big section in the policy around consent. There is also a big section around communication that will be included in the code and the toolkit, and we expect that when somebody is referred onto the dynamic support register, they are communicated with. And as part of the code and the toolkit, we are asking areas to really think about how you will communicate with people and their families and their circles of support, because people need to be informed of decisions that are made. They need to know when those decisions will be made. So absolutely, people should be informed at every stage and included at every stage.
Okay, thank you. And should a CTR still be held on discharge from hospital to residential step down? Where does a CPA fit in? I'm not sure what a CPA is. I'm going to let Chloe answer. Clarify.
CPA is the
care programme approach.
Yeah.
So when we've talked about moving to system ways of working and being system led and people developing systems that work for their people, I think that's where the CPA fits in. When the policy was rewritten and we knew these changes were happening, we have started to progress to look at having a real multidisciplinary approach. In an ideal world, the dynamic support register into the CETR and the people who they communicate with should be streamlined, and the information that I mean, the CETR in itself is an independent review of that person's care. However, it's only part of that whole jigsaw puzzle, and really it's about having better communications with people. So it absolutely should fit into the care programme approach, and people should be feeding in and out, much as Scarlett and I have lots of conversations about ensuring that the outcomes and actions of a care education and treatment review are handed over. Sorry, got a bit of feedback then. Are handed over to people who are leading with that person on the dynamic support register. So yes, CETR should be held on discharge from hospital to residential step down. They should be held on transfers between any care, whether that's stepping up or stepping down. So yes, I'm not sure who asked that question. It absolutely should happen.
Thank you. Sarah's asking another question. Will a diagnosis still be required for entry onto the DSR? This is a major barrier for individuals because of the waits for assessment in ASC and LD.
Yeah, I think that's a really valid point. What we're saying, this policy is for those with a diagnosis of learning disability and autism, and as a minimum they must be the standard as to who should be on your dynamic support register. What I would say is, from experience of being a children's commissioner, I had previously had undiagnosed children and young people on our dynamic support register in recognition that if they were to go into hospital they would be likely to get a diagnosis, and therefore it was in everybody's interest to have that young person on the DSR so we can support access to timely intervention. Whether that's the same in your local area will be dependent on the criteria for inclusion, and what I would recommend is that you get in touch with your local ICB and talk about who should be included on your local dynamic support register and how you're going to develop that.
Katie is asking, DSRs, is it DSRs, if it is a self-referral, who decides if they're accepted? Is there standard eligibility and criteria?
Who decides they're accepted, and the eligibility and criteria again is different in different areas. You need to work with your local ICB to develop what that criteria is. You know, the policy is very clear that this is all dependent on local co-production and what is right for your local system. So I can't emphasize enough the need to get in touch with your local ICB and develop that together, and not only develop who is included, but who isn't included, and be really clear about that.
And I think, sorry, just to jump in on the back of that, Jackie, I think one of the things that we've really been made aware of from working with people like you, Jackie and Amanda, is I imagine a lot of the people on this call are thinking easier said than done. And we are trying to empower people to ask the right questions and to hold people to account. So within our toolkit, what we have promised that we will do and absolutely are on with is we will make sure that we have links to people's areas. So we are currently putting a challenge into our regions, of which there are 7, our integrated care systems, of which there are 42, because we have given delegated responsibility. Each area will have, for the care education and treatment review aspect of this, will have an oversight group where the senior responsible officer for delivering the standards and the policies will be part of that. And absolutely, we're giving them until the 1st of May. We have to give them a bit of time to get ready. But once we publish this on our NHS England website, there will be those links, and we are having a specific area for parents and carers because that co-production element of it is essential. So we just need you to bear with us a little bit on pulling that information together, but it will be there.
And in the interim, contact details for your local ICB are available on their website.
And Pippa's asking, CETRs are still being facilitated mainly in a virtual context. Are there any recommendations around this? Options aren't being provided to children and young people, adults and families to meet face to face.
Hi, Pippa. Yeah, unfortunately, this is something that we are hearing quite a lot. And I think prior to COVID, all CETRs were held face to face. So we do know that it can be done. Microsoft Teams and Zoom is only something that we've learned over the last couple of years. So what we've done within the national team is we've looked at all the learning and feedback from working remotely and undertaking virtual reviews. And we do get feedback around there being some benefits for panel members, you know, and that's the same for experts by experience as well. And some of you people on the call today may support your local systems by working on panels. We do have parent carers across panels working as experts by experience. And, you know, we do actually have some people saying on the receiving end of the review and the parents that they feel more comfortable speaking to a panel remotely rather than face to face. However, what we found within the safe and wellbeing reviews and what we found in audits is that actually concerns and poor care don't get picked up during virtual reviews. So within the policy, we have absolutely highlighted that there is a requirement for panel members to attend face-to-face reviews. That will also be within the key lines of inquiry, so the template that we've talked about. And we will have those two elements that people have asked us to include. So that will be the sit and see element. So somebody from the panel is going in and having a look at the environment. If that person's an inpatient, if the person's within the community, they'll be going and seeing where that person's living. If they're at residential school, they'll be going to where that person is or at college, because I know when I joined in October, and I do spend quite a lot of time looking a bit shocked, that if someone said that they'd reviewed me, but they hadn't met me or seen where I'd lived or spoken to my family members or carers or advocate, that's not a review. So our national steer, very clear steer, and our senior responsible officer who's worked on this, Sue North, we are going out to all of our regional leads and we are feeding back to all systems that absolutely each care education and treatment review, there has to be that face-to-face element. So I push back, Pippa, and if they say that shouldn't happen, then actually reach out to your regional and national leads. And we do get involved in conversations like that where people are really struggling. We do have an email inbox, which I can probably put into the chat if I can find it, or Michelle might be able to put it in the chat, which is ask, listen, do. And we do find ourselves in positions where we're having to support people to ensure that their person or the person themselves gets that element of the review. So I hope that's been really clear. And I guess the bottom line is it absolutely should be face-to-face.
Thank you. Next question is from Lisa. She puts, I understood that all boroughs need to use the same template for a DSR and the questions asked. Is this still the case for doing a RAG rating?
No, so there isn't a specific template that we've endorsed. There are key data capture requirements that we've asked to be included in every dynamic support register, but it's up to local determinants how they capture, what they capture, but there are some minimum requirements of what they need to capture, which are included in the policy.
Great, thank you. Another question from Sarah. Will there be a clear message from the national team to local teams about the fact that the local threshold can be developed to respond to local need?
That I think is included in the policy already. Is there a specific, I mean, what we've said about implementing dynamic support registers are the sort of minimum requirements of who needs to be on them. We have not said that that's all that you need to do, but this is saying this is to get some consistency around the country so everybody knows what you should receive as part of a dynamic support register and as part of a CETR is included in the policy. What we're asking is that this doesn't describe what happens in your local area. This doesn't describe what your local makeup is. It doesn't know whether or not you've got 2 or 3 key working services. It doesn't know what intensive support you have. This policy is about saying you need to support children, young people and adults who have autism or a learning disability or both, and we need to prevent them from going into hospital, and here are the tools to do that through dynamic support registers and CETRs. But that's not going to prevent a person going into hospital without being aligned to what your local needs are.
Could I just come in there, Jackie? Just to,
Yeah, please do,
say,
Sarah.
Yeah, we've been working around implementing national policies locally for a long time, and what we know is unless there are very, very clear messages, then it gets lost as it comes down the system, and the systems are under such pressure at the moment, they find it hard to sometimes deliver that really personalised approach, and sometimes the voice of forums are lost, particularly where the relationships aren't particularly strong with the ICS. And, you know, the ICS is thinking about a lot of things at the moment, and we're one voice. So, you know, what the work we've done with the DFE in the past and the NNPCF have promoted in the past is about, you know, very clear messages about working with forums, but also around, you know, clarity, not just in policies, but in the supporting information that goes out around where there are areas of flexibility, and the expectation that ICSs will explore that. They might not, you know, that might not be the, I'm not saying that they'll agree with everything that forums say at the end of the day, but they actually will evidence that they have explored, you know, the discussions that needed to be had. Because our experience is that doesn't always happen unless we are supported by national teams to make sure that does happen.
Yeah, absolutely, Sarah. And I think that's what's different about this particular policy is there is a list of minimum requirements and minimum standards that absolutely have to be implemented. And the new draft mental health bill will support us doing that when it gets legal assent. Similarly, the SEND inspection framework has got some clear messaging around what needs to happen and it's being inspected as part of the local area inspections. So I think we've got some more levers than we've ever had before. And the code of practice and the toolkit that's currently in development will help to strengthen what we've put in the policy. And what we'll be looking to do once we've got that developed is to produce a parent guide so that we can share with you what our expectations are of local systems, and you can share with us what they should be as well and help shape it.
Okay, Dave's got the next question. If the child or young person declines a CETR, does it just not go ahead? A 15-year-old declined the CETR and it didn't go ahead, yet they are still on a ward, and so the Chloes weren't followed up from prior CETR.
That's a really hard one, Jackie, because it's about that person as an individual and capacity assessments, and 15 is a very tricky area as well. Just thinking back to, you know, my clinical work, so it all depends on that person. We have questions coming in quite often from family members, and it's certainly within our FAQs around that kind of like capacity, information sharing and consent. So yes, I think I totally appreciate that it would be really difficult, because if they'd had good actions and the outcome is this person is still within a hospital ward, it's not ideal, but it's a really difficult question to answer without knowing a bit more information around it. We now have within our assurance and oversight support for integrated care systems, we've now got an escalation process in place. And similarly to, I guess, the question that Dave's asked, this has come from areas where people have been concerned about where people haven't wanted reviews, and what happens now is if a person declines a review twice, so and that would be more regularly, so if the person's within the community and they're on red, they wouldn't be getting reviewed as often as they are if they're in an inpatient facility. So actually for a children and young person, it should be around every 3 months that this person receives a review. So once they have declined twice, then they will have to follow through the escalation process where a group of senior leaders, senior clinicians will review that case. So I think previously maybe there wasn't anything as robust, but there are absolutely things in place now to ensure that if needs be, they will look at that kind of capacity and best interest assessments and looking at how they can support that person.
So similarly, Carolyn asks, so a young person who doesn't engage with any services and doesn't give consent wouldn't be on the register?
If they don't give consent, no. But what I would expect is that there's a conversation happening with the person that has made the referral. So if it was a parent that was to ring up and say, my child doesn't consent, but this is what's happening, I would expect the person that answers that phone to have that conversation, to listen, to signpost, to make suggestions, and encourage them to keep in touch and to be there. And I know if Yvonne Newbold was here, that's exactly the intended purpose of having the right to self-refer, is that we have a conversation, we listen, and it may not be that they would have been appropriate to go on the dynamic support register, but there may be a service in your local area that you could signpost somebody to. And it's, you know, we need to make more time to listen to people. And that's part of the reason why self-referral is just so important.
But I think as well, just to add to that, I think, you know, the issues around capacity and consent need to be better understood. So if, you know, if young people are taking medication and that might impair the capacity to consent, or if, for example, they have a learning disability that impacts, then, you know, family carers like me can and are deputies. So we consent in place of our young people, even where they're over 18. So I think it is an area that it is important for families to need to understand more about, the whole issues around, you know, consent, capacity, when you might have fluctuating capacity, when you might have capacity that's impaired, and really have those sort of more in-depth conversations, and also recognize, you know, your own rights as well to, you know, to become a deputy, and as more families, carers like myself are becoming. And so I think it is something that we all need to know more about. But, you know, this isn't, as Scarlett said, about, you know, turning people away, because, you know, as part of, and what I said at the beginning, you know, these are policies to help people in quite acute levels of need. But the dynamic support register is also requires, you know, population-based planning around those who are, you know, not on the register, you know, thinking about the needs of those in the wider population, you know, the issue of joint strategic needs assessment. So it isn't simply, oh, we have this, you're an acute need, you can't get anything. That, you know, we all know, you know, special education needs and disability, community services require that there is help for people, you know, when they need it, from social care and from other places. So, you know, this is part of a continuum of support and care, and, you know, everybody needs to be heard, listened to and supported.
Absolutely.
Okay, Carolyn says, you mentioned a risk assessment tool. Can you write it in the chat, please, if no one's done that already?
I can probably do better than that, actually. I think the Cheshire and Wirral model is included as a link in the policy. So after this, I'll tell you what page it is, Amanda, or whoever will send out the slides, and we'll include it as a link so that you can have a look at it.
Thank you. So the next question is, a CETR is only held when moving from one care place to another. Is that right?
Thanks, Jackie. And I think there's one below it as well that Katie's put in about, there's about a whole chapter there's definitely a whole part of the appendix on what triggers a CETR. So the reason why we have brought dynamic support registers and care education and treatment review policy together is because, well, for me, especially as a new person, it makes sense. So if you are on red, so at risk of admission, on the dynamic support register, you should be having a care education and treatment review. And that is so we can support that person to stay within the community. Because we, oh, sorry, go on.
Just to add on to that, Chloe, if they're identified as red, not only should they have a CTR, they should also be referred to their local key working service if they're not already known.
So it's yeah, there's quite a lot of different triggers. So one of them is if a person is an inpatient and moving place to place. A lot of CETRs happen within the community, and it's about having that independent review on what's happening within the community and looking at how they can work as a system, which is why holding them at place is the right thing to happen, how that system can work together to support that person from not going into hospital in the first place. So it absolutely is about doing them within the community.
Okay, thanks. So that should answer Katie's question as well. So I'll move on to Sarah. Again, there needs to be clear messages from the national team about the ability to be flexible around the diagnosis requirement and the ability to respond to local need. That's a comment.
I think we've probably already kind of covered the diagnosis element, but just to highlight again, the policy is really clear that it's for people with autism and people with a learning disability, in recognition that there is a need to support this community more than others.
A comment from Amanda: some areas have existing eligibility criteria, so the challenge for forums is review those and taking ideas to the ICB to improve them. It can be hard to get systems to change existing practice. That's her comment. And then moving down to another question from Amanda. If the ICB are responsible, is it still likely they will delegate to PACE LA's level, and will criteria be different across place? Even
sorry, that's place, not PACE.
Place, sorry, even though they're in the same ICB system. So did you get that, or do you want me to read that again?
No, that's fine.
Yeah.
Thank you.
Oh, sorry, go on, Scarlett, you go.
No, it's fine, you, Chloe.
I think it is so different. It's so different across each area, and it's the same for, so Pippa's asked a question around whether the integrated care boards will be responsible for the recruitment of clinical experts and experts by experience. I think the message that I would give to you all is that this is currently being explored, and what we're working really hard to do is we talk about minimum requirements, and we're not saying to people, we're not saying to systems, do as little as possible, do the minimum, but what we are saying is you absolutely have to meet these basic standards, and they're not basic, they're pretty robust actually, to hopefully make you feel a little bit more assured around what we're trying to introduce. But then what we're saying to systems is you now need to engage with your people, you now need to engage with people not just within NHS providers, but people within local authorities and Department of Education to build something that meets your people's needs. So although we're saying that the integrated care boards and integrated care systems are very different, we are trying to support them to move to having a consistent approach. And I know from the patch that I'm from, so I'm from North Eastern Yorkshire, I know that North East and North Cumbria and Humber and North Yorkshire, which are two of our integrated care systems, are a bit slow. But then I also know that we've got West Yorkshire and South Yorkshire who are absolutely running with this and have developed some fantastic systems. So what we're hoping to do within the toolkit is to support them by sharing good practice. So again, if people are really proud of stuff that they've managed to do in their areas, then please get it through to us, because actually that'll avoid people duplicating work that's already been done, and hopefully give people that light bulb moment, because we're constantly being told, oh, that will never work. And you know, Scarlett and Mary and I sit there saying, but it does work in some systems.
Absolutely. And I think there's also recognition, and this is partly why we've given a good 3 months for areas to implement this, is that where dynamic support registers sit, where experts by experience are recruited, where CETRs are coordinated, is all very, very different, and dependent on whether you've got a key worker service in your system, your dynamic support register could be sat within that key worker service, which is buried within a voluntary sector organisation, or even in one of the hospital providers. So there's a lot of work going on in the system to unpick that and redefine it and make sure that there's the appropriate oversight as required in the policy.
And it's
really
I was just going to say, it's a really big transformation, and we know that things need to be done very differently. So where we've got a real focus on that quality improvement and transformation at a national level.
So I'm really conscious of time. We're almost at the end of our session, but I think we can probably just squeeze in the last couple of questions. I don't know if Carolyn wants to come in. You made a comment when you obviously responded to something where you put, when you say we listen, who is we? I wondered if you wanted to come in and clarify what that was in reference to, Carolyn.
Hi, yeah, Scarlett, I think you said, you know, if someone doesn't want to be on the register, but we'd have that conversation, we would listen. I'm sorry, I'm phoning as a parent and a PCF member, and I don't really know. So who would I call?
And I think
who's we? I don't know who we is.
I think that's a very, very valid point, Carolyn. And I think that's the bit that, as Chloe described earlier, we're still trying to unpick so that we can get it published on our NHS England website, so that there is a contact number for every ICB area to pick up the phone and say, I need some help, I want to refer this person or myself onto my local dynamic support register, so that you can have that conversation. So we don't have that ready to share as yet, and like Chloe said at the beginning, we are still in a position where we're in implementation phase. So from the 1st of May, that's when we want to have those contact numbers available, so that you can pick up the phone and have that conversation.
Okay, thank you. So in the case of, you know, in my situation, the young person would have nothing to do with it, but you'd have a conversation about other places to go, or?
Yeah, there should be some signposting. So there should be so self-referral is really clear, that there should be a way for you as a parent to refer your person, or for you as a person to refer yourself, and that you can have a conversation with somebody to discuss what that looks like and what that means. And if the decision is that you're not eligible to go onto your local dynamic support register, well, what support should you get? How can you get some help to help you stay well? And that was the feedback we got about having no wrong door, and why self-referral is so important.
Okay, thank you.
And I think I'll just add to that. I think that's why it might be useful to get Verity to come back and talk about carers contingency planning, because when I first heard about that, and you know, that's a really important offer, new offer from the NHS to care better for unpaid carers. You know, Verity said to me, you know, what family care, what groups can we link to? And I said, well, you could link to this group, Verity, because I mean, I know the strain for families, having met so many, of, you know, supporting young people who are in crises, trying to get your family together, and, you know, working and everything else that we do, you know, as unpaid carers. And I think the contingency planning process, you know, allows that to be formally understood and embedded and sort of registered with your GP. So I think that's something that's really important, that's practical and important, that, you know, within the system recognizes, you know, we can't just all keep going. You know, my son had to go away to residential care because we couldn't keep going. And, you know, that was avoidable. But at the time, we didn't have key workers, care education and treatment reviews. We didn't have dynamic support registers. If we'd had those things, as we heard recently from families on the key working webinar that we had, which was really wonderful, and I've put the link in there. So all areas now either have key workers or they will have key workers, and we're on schedule for every ICB area in England to have key workers, as was set out in the long-term plan. You know, if that had happened and you hear the stories of families who've had that practical help, it has transformed their lives. It has meant, yes, you absolutely can. Yes, contact Verity. So I will give Verity's details. And I think it might be worth Jackie and Amanda inviting Verity to come and talk to you, because it's important you hear about what NHS England and others have to say about unpaid carers and your rights, and how you need to be better identified and seen within local systems as well. And there's a whole other group of people who are doing that on your behalf. And, you know, Verity's part of that. So I think that's a really practical and positive thing as well.
So someone asked where they can find out more information on key working. So where's the best place for them to look up information on that?
I've just put in the link, Jackie. That's the main source of information. You have got the most wonderful colleagues who work with us. You are our key. We've got the top-notch best people from the NNPCF working with us on key working. Joe Harrison, Rosloff and other colleagues, you know, so if you would like a session about key working, you know, from them and from us, Kate Sutton in our team leads this work, you know, we'd be very happy to do that. So if you would like in your feedback to reflect on that, then, you know, Ros, Joe, others of your colleagues, Amanda, you know, Kate Sutton, we could come and talk to you more about key working. The link is there. All areas are covered. All areas have funding. It's really important. And similarly, yeah, Verity and the carers, your carers' rights, and helping those be better seen in systems as well.
Absolutely. And I know that there's some information on our website around our involvement in key worker as well. If people go to the NNPCF website. Amanda.
Yeah, I just want to thank our NHS England colleagues for being so dogged around this policy and so committed to wanting parents via forums to help shape and drive and co-produce around this, particularly given the latitude that the integrated care boards and systems seem to have. You know, from the top there will be messaging, but also, you know, forums, if they can find the time and the inclination, particularly if it's an issue in your area, to raise this. I did speculatively wonder if any forums would find it helpful if I drafted a template letter for them to introduce this to their ICBs, to the key people, and I'm happy to help with that. If you want to contact me, it's just an idea. It may be that you're perfectly capable of doing that, or if you just don't have the capacity because you're so busy. So I'm open to that. Amanda.elliott@contact.org. I'm here to help with those sort of things if you want them. But a massive thanks to Mary, Chloe and Scarlett and also Jackie and all of you guys for being patient with us and listening and asking great questions.
And just to add, finally, you know, we understand and try to really advocate for this group of families and those who are really struggling. And so family trauma is a big priority of mine, and we have commissioned work around that, understanding of it. There's some research published, and you know, so we know that this group of families are often traumatized as well, and that's something our key workers understand. So we do and hear how difficult all of this is, and we are trying really hard to make sure systems understand and care about you and your families. Yeah. Yes, Leslie, lifelong trauma. And it's important people understand that. So we're not seen as those difficult and troublesome parents. We're actually traumatized, you know, and there are reasons for that. So Chloe's team, we've commissioned new training, and all our regions really understand and care about that.
Cool. Is there any other questions, or just a massive thank you to you guys coming and talk to us? And please do contact us separately if you want a little bit of advice or to talk things through or whatever.
Thank you.